for the audience, I would like to share that diabetic retinopathy, when you are looking at, when you understand the basic pathophysiology of diabetic retinopathy, is the vessels that get obliterated. So when you do an foveal scan in these patients, you look at the decrease in the vessel density, means the number of vessels in that particular area. It tells you that the OCT, the diabetic retinopathy is progressing. The phase size increases, the vessel density goes down, and this tells us that there is a progression of diabetic retinopathy. This is how OCT angio is useful in diabetic retinopathy. Apart from that, has been mentioned by sir and other experts. So now I go to the another very important topic, which is about IPCV. IPCV has been always in the domain of ICG, and there's a new terminology which has come in recent year, is non leaky MNVs, which have been there, which have been evidently shown on OCTA. Before that, we didn't know much about these identities. So now for this, I invite Dr. Bhuvan, who is a very sought after vitreoretinal surgeon in private practice. He is currently working as a chief vitreoretinal surgeon in Bharti Eye Hospital, New Delhi, and he is a very avid speaker and is very much invited into various international conferences. So, Dr. Bhuvan, sir.
Yeah. So thank you, Ankur, for the introduction. Very good morning to all the chairpersons and audience. So I'd like to thank AIOS. I'd like to thank Ankur, and a very nice opportunity to meet my old friends. So I think we are discussing OCTA. I think OCTA is the future, but definitely we have discussed the limitations and also the advantages. I'll be discussing the role of OCTA in PCV and non-exudative MNVs. Although I think OCTA, before starting my presentation, I'll say that for PCV, OCTA has huge limitations, but probably as newer models comes and the progression comes, probably we'll have more information. So I will not go into the details. I think PCV is a group of disorders now, is a part of a group of disorders known as pachychoroid, and which involves diffuse thickening of the choroid or of the choroidal vessels, or a focal thickening with dilated middle and outer choroidal vessels, and severe atrophy of the overlying choriocapillaries. So ICG was the gold standard for detecting polypoidal lesions, and they are seen as hyperfluorescent fluorescent hotspots, and they gradually the hyperfluorescence increases. Sometimes there is a hyperfluorescent area present around the nodules. So even OCT has a high sensitivity, but the specificity is low in detecting polypoidal lesions. These are typical pictures: a tall peak PD, a double peak PD, a large PD, a thumb-shaped PDs. So all these things, they are associated with polypoidal in about 75 to 80% of the cases. But even there is a possibility that even if OCT is showing such pictures, a polyp may not be present. But there is a sensitivity is there of around 80%. So now just showing you, this is a polypoidal lesion in a study which was published. So this is the ICG picture, which is showing a hyperfluorescent spot. And when we do a B scan OCT, we can see that there is presence of a polyp at the height of the PED, and there is an adjacent double layered sign showing the splitting of the RP and the Brooks membrane with a choroidal neovascular membrane. Now this same picture we compared in the study, they compared with the OCTA images. So the OCTA images, which is done at the outer retinal slab, you can see this marker. So you can see that there is this in the at the D slide, there is this white half circle which is corresponding to the area of the polyp which is seen in the ICG. Now when we go to the deeper levels in the F slide, in the choriocapillaries, we can see that there is presence of this branched vascular pattern which is corresponding to the choroidal neovascular membrane in the ICG picture adjacent to the polyp. So now when we go to the G slide and we do a color composite, then we can see the circle on the left side would be marked as a polyp, which is seen as a half circle. I'll just tell you why it is not so well demarcated and why it is a half circle. And adjacent to that, we can see that there is presence of the choroidal neovascular membrane. When we correspond this to the B scan in the H picture, then we can see that the polyp in the color composite is shown in the height, near the height of the PD, and the adjacent choroidal neovascular membrane can be seen. So as can be seen in this slide, the polyps are not very well defined in OCTA, and this is a limitation because the OCTA is based on the blood flow, and the blood flow in a polyp is usually very less. In larger polyps, the blood flow is usually higher at the periphery, and that is why you can see the presence of a ring sign or a half ring. So it will basically pick the outer edges of the polyp. So this is another showing the different patterns of the polyps which can be seen on a OCTA. So again, as I said, this is the A2 is the ICG picture in which you can see a well-defined hotspot. There is a nodule, but when we do a OCTA, we can't see a well-defined polyp, but however, a circle lesion can be seen. So this is because the blood flow is higher in the outer part of the polyp. It results in the formation of a white circle. So another picture in which a cluster of polyps are seen on ICG. If we do a OCTA, then we can just, this encircled red spot, we can see various small white hotspots which correspond to a polyp. So you can see most of these studies have been retrospective. So if we do a OCTA and try to pick up a polyp, sometimes it's very difficult. Maybe if we already know there is a polyp, by doing end-phase images, we are able to pick up the polyp, but ICG based on all this, I think, is still the gold standard for diagnosing a polypoidal lesion. So these are the other patterns which can be seen on ICG. If you can see in this C2 picture, there is a very clear clusters of polyp which can be seen. However, again, if you do a OCTA, then there will be presence of these polypoidal lesions as small white lesions or half circles which can be seen because of the limited blood flow. So the last picture is again shown a small polyp, but however, since the blood flows in small polyps are very less, we can't see any well-defined pattern which can be seen on the OCTA images. So as I said, the slow velocity of the blood flow which is present in the polyps, it can't be captured on the OCTA machine, and the flow velocity which is present at the periphery of the larger polypoidal lesions is much more faster. So usually we get a half ring or a full ring formation, and sometimes the polyps are so small that they can't be picked up on an OCTA machine. So this is just one patient. You can see in this clinical picture there is a large PVD, there is a white membrane. So this is the OCTA images. There was a large PVD on the OCT images, suspected polypoidal PCV case, but when we did a OCTA, we could see a vascular membrane, AVN pattern could be seen. However, no well-defined polyps could be seen. So based on the picture, there is presence of a half white circle, which could be a possible polypoidal lesion, but I was not very sure. So I went with the ICG, and when you do a ICG, then you can see that there is a clear defined hotspot nodule which is present at the edge of the PED, and there is an adjacent branched vascular pattern is also present there. So I just wanted to highlight that ICG is still the gold standard if you really want to see a polypoidal lesion. Also, if ICG is not there, we have a OCT and OCTA which gives us a very high sensitivity and specificity, and and based on our clinical findings, we can make a diagnosis of PCV and treat the patient accordingly. So now I'll come to the second part, that is the non-exudative MNV. I think in the first presentation only Vinod asked a question, and the major role of OCTA was highlighted, that is to see occult CNVNs or MVNs and the FAZ. I think this is the mainstay for today, even for a basic OCTA, which is there, and it can't replace the other invasive procedures for that. So non-exudative MNV is one thing which can be seen by a OCTA, or it can be seen as a hotspot on the ICG. The definition, by definition, there is no presence of any activity, there is no macular fluid. It is an asymptomatic condition. The fellow eyes of patients, in 6 to 27% of the cases, they may have a exudative AMD. Incidence of exudation ranges from 20 to 40%, hence OCTA is a very important tool for following up such patients. So as long as there is no exudation, the studies which have been done, they said there is no need to treat it because most of these membranes are mature and will not lead to any active lesions in future. So as compared to angiography, fluorescein or ICG, I think OCTA is a much more faster non-invasive technique which can easily pick up these membranes, and then they can also easily be observed, and hence OCTA is the prime indication for the diagnosing as well as the observing such lesions. So again, with OCT, we can see these lesions, which can be seen as the splitting of between the Brooks and the RP layers, but it is not as sensitive and specific as a OCTA in which we can see the proper vascular network. So this was a study which was done by Wang in 2022. In this, they were observing the MVN lesions over a period of time. So this is one of the lesions which showed that around 12 to 13 months, the membrane not only lead to exudation, subretinal fluid, and intraretinal fluid, but also the size is also increasing with time. So OCTA becomes a very important tool in monitoring such patients. And then they treated it subsequently, and then based on that, only an OCTA was done for the follow-up, and the whole management was planned by OCTA. Similarly, this is another lesion in which they said over a period of time, there was no activity, there was no reason to treat it. The lesion size increased over time, however, there was no exudation. Hence, it's very important to keep on monitoring these lesions and also educate the patient that if he has any distortion in the vision, then probably he should come for management. So, just my final few slides. OCTA studies have shown that large MNE complexes, they do not disappear with any treatment. Hence, there is no need to give anti-VEGF agents. Sometimes these membranes are also protective. They prevent the development and the progression of geographical atrophy. Hence, further no need for treatment, and most of these membranes are already matured also. The goal of future treatment will not be to eliminate these membranes, but to promote their maturation and prevent the exudation. So not anti-VEGF, but maybe some other form of treatment may come in futures. So as I said, they also prevent and they also slow the development of geographical atrophy. They have a preventive role, similar to these persistent subretinal fluid. So just the final slide. I think multimodal imaging, they have really helped the understanding the pathophysiology of PCV. And OCTA is a very important non-invasive tool for detecting the blood flows in the PCV. However, it has got a very limited role. It will only detect the blood flow in the large PCVs at the periphery, and you will not have a well-defined polypoidal pattern, but you may have a ring or a half ring or a cluster of white dots depending on the blood flow which is present, and it can easily miss small polyps. So ICG still remains the gold standard for the detecting PCV. But you can avoid it in your private clinical practice at least. Maybe in an institute you can do it in every case. So, and for MVNs, I think OCTA has really helped us improve the detection of occult CNVNs, non-exudative MNV without any invasive and a very fast procedure. And these membranes have to be observed over time, and there is no need to no need to treat them if there is no activity. So thank you all for listening. And this is
Any questions from the audience?
So first of all, PDT was sorry, that's what I said. PDT was not available, so that is why we were not doing it. I am not saying that you do ICG. ICG really helps to make you a diagnosis that this is a PCV. So a PCV management is slightly different from AMD. You know, in PCV you have to be slightly more aggressive. You have to even tell it may be associated with more risk of subretinal hemorrhages. So you have to also educate the patient. So that is an important part of first of all detecting PCV. Secondly, there are certain anti-VEGF agents which also are probably more better. They respond to a polypoidal lesion as compared to a AMD lesion. Not in 100% of cases. Most of the times it can tell you. And if there is an extrafoveal polyp, I think that is a very important thing. Yeah, of course. So that's what I'm saying. You can avoid a ICG, but if you have it, then it's always better you should do it.
There was a time, I think, we for a very short period we were not doing, but I think if you routinely start doing ICGA, even in today's scenario, you will find at least 20 to 30% of the lesions are outside the FAZ. So even if they are in the macula, you can directly laser them. So I think even in today's scenario, it's very important that you do ICGs in all these patients. Once you start monotherapy, it's never ending game, you know. It looks very nice, but it's a never ending game, and patient virtually are always on anti-VEGF therapy. But once you laser the polyps, the BVN part is very easy to tackle. So it's important to find the polyps even now, I think. 30% of the lesions, those 30 patients do not require repeated anti-VEGFs if you knock away the polyps.
So I agree with Vinod. Just again, fully agree. That is what I'm telling you. But sometimes, in private practice, the cost is there because you have to charge for ICG every time. That is the only thing. So I agree. So that is why I highlighted from both points. ICG is very essential, as Vinod highlighted, but sometimes you can just get away. Maybe if he's not responding, do ICG. But if you have the facility, patient is ready, it is always I think it is very important to do it, as highlighted by. So I just wanted to ask, since you are working in Institute 3, any other points with your higher end machines you see on a polyp which probably we are missing, or any other information we can get with the OCTA on PCV?
You see a ICG of PCV, just the ICG. I think 99% of the people would be able to tell that this is a PCV. Okay, but you just show a OCTA, just the OCTA, to anyone, and only 5% people will be able to tell
So
that this is a PCV.
even the most
I'm talking about single imaging modality. So, but once you combine OCTA with OCT and fundal knowledge, so everything put together, yes, you can get a fair bit of idea whether you are dealing with PCV or not. But that's why the ICG remains the gold standard. And one thing I learned over many years is that the percentage of eyes you are going to pick polyps if you do ICGA at the onset, at the first visit, is much higher. If you treat them and then do ICGs, then the percentage of eyes where you can pick up polyps is much less, because the picture gets altered. So it's always easier to do ICG and pick polyps in the first sitting rather than later on.
And on OCTA, most of the polyps, in all these studies and everybody are picked retrospectively. There is no study which is saying that we have picked up the polyps and.
I'm so sorry, I have to
Yes.
interrupt. We should go next topic, please. We have just like